There's tea and food upstairs. You just go up the steps up there. How are you?
I'm okay in here.
Yeah, I'm alright. Thanks.
The address for, I assume we're live streaming, right?
Yes. I sent it to Lisa.
Yeah.
I can mail it to you. You want me to mail it to you?
No, it's okay because I don't have my phone.
Okay.
I'll ask her to. Yeah.
Or do you want me to mail it to someone?
Just mail it to me. I'll find it.
Okay, so I'll manage the no, that's the thing is, it will be not absorbing some time. Yeah. So this is going to get some gain. So there's going to be a little bit of so so it's going to stay within like 20 minutes, but we're going to absorb some time as well. So all I'm saying is I'm fine. And if you wave the numbers at Lucy, she's going to freak out.
Yeah, but make sure
Make sure that she's here.
Yeah.
We know now.
now.
So it's not
People are coming in now. Last time I was because I thank everybody.
okay, let's do I'm so
Yeah, let's do it. I'll switch to you now. Because at the end we might have some other things.
okay, sure.
Hello. Yes, and he's precious.
Do you know what?
You know what? You know all the positions at the time.
Yeah.
Okay, cool. So I don't have to do it.
Yeah, no, you don't.
One
Yeah,
thing
that's yours.
so there's 10 minutes and then 3.
13.
And then those on
Or the 10 minutes and 20 minutes.
10 minutes. Because you guys have to do it. Okay, so they've got 10 minutes and 3 minutes, and then there's 2 posters, 2 minutes and 1 for well, there's 2 minutes for presentation for each of these and 1 minute for discussion. Okay. Shall I start?
Well,
Mr. Type.
Good morning, everyone. We are going to start. So welcome all of you to our 5th annual research day for the School of Public Health and Family Medicine. And I appreciate that you've come for an early start. We have a full day, lots of discussions. The research day is a special time for us because we're a very active school, which is very noticeable in terms of the fact that we're ranked 40th globally in terms of public health schools and programs. And we're in the top 10% of global public health programs. So we're a very busy school, we're a very active school. We produce lots of research and teaching and social engagement, service, and leadership. So today is a nice time for us to take a pause and to just have a snapshot of what it is that we're actually doing. And we don't do justice to all the research that we're doing, but at least it gives each unit and division an opportunity to showcase some of their staff's work and some of the students' work. And so I ask you to, ask questions or write down if you've got questions, to take note of them, and we'll try and engage them as we can as we move along. And I'm glad to see that we have some of our support staff here, because I think what makes our school great is in terms of our research, but also our support staff who made it possible for us to do good research. So I'm glad you're also coming and listening as well. So I want to first just briefly, I'm not going to talk a lot about the school. So basically, for those of you who don't know, I'm Andrea Rother. I am the head of the Departmental Research Committee, and I'm also the head of the Environmental Health Division. We have 8 divisions in the school, and we have 2 research centers and 2 research units. So we have the Center for Infectious Diseases, Disease Epidemiology and Research, CIDR, and we have the Center for Environmental and Occupational Health Research. We also have the Health Economics Unit and the Women's Health Research Unit. You can see I'm not testing my memory. I'm looking at my crib notes. We have 8 divisions. We have the Public Health Medicine, we have Occupational Medicine, we have Family Medicine, we have Epi and Biostats, we have Health Economics, Health Policy and Systems. We also have Social and Behavioral Sciences and Environmental Health. So it gives you a good snapshot of the diverse focus areas that we have within the school. The way that we've set up the research day is, if you look at the agenda, you'll see that we have 5 panels, and those panels incorporate our divisions and our research units and centers. so that we can showcase the work that's being done. I started doing this 3 years ago, and we brought in this idea of having student posters, and that's been the highlight of Research Day, is the student posters and the student presentations. And this year we've decided to incorporate them within the panels. So we'll actually have the students talking within the appropriate panel that they fall in, the division that they fall in terms of what they're studying. So you'll see that we have some selected student presentations. We also have posters upstairs. So those of you who've had tea already this morning, you'll see just upstairs, that's where we're going to have our tea and our lunches. And we have poster presentations there. We've asked the students to stand by their posters during the teas and the lunchtime. And if you can speak to them and ask questions, that would be great. So I'd like to first do a few thank yous. Research Day is definitely not a one-woman show. It's about a 8-woman and a man show. And so I'd like to thank my team who's made it possible. There's been a lot of hard work that goes on for a better part of 6 months to make this day happen. So John Pachaguba, who is the deputy head, I don't know if you want to stand up, and Lucy Hanema, thank you, and Jill Oliver, am I missing? Jane Harries, if you can stand up. Thank you. And Marianne, where are you? Marianne Davies. Alison is not here? No. All right. And then, of course, the main person behind the scenes is Liza Smith. So, Liza, if you can just come up. Say a big thank you to you. Thank you. Liza's been doing all the hard work and making sure that everything's been happening. So this year we had decided to have the theme of looking at public health and the challenges that public health face and can add to in terms of engaged scholarship. And the idea with that was to lead into then Prof. Khan, who is the Deputy Vice Chancellor for Research and Internationalization. And that's very much her area. She's very keen on engaged research, scholarship. And unfortunately, as she was on her way here, Max Price pulled her into a crisis meeting. So she's not going to be able to join us this morning. She may try and join us later this afternoon, but we have agreed that we will do a separate session where we talk with her about engaged scholarship. But she has given me the two sort of themes that she wanted to talk about, that she was thinking about. And I mean, she just gave them to me about 20 minutes ago. So what I thought we would do for the next sort of 20 minutes is have an open discussion to set the platform for the panels in terms of what we think about engaged scholarship, and particularly what Katie, her 2 points that she wanted to make. Because what I've asked is that, or what we've asked is that each presenter, their last slide, will be speaking to engaged scholarship. And you know, we tend to use a lot of these words and they become buzzwords, and we lose the value of what they actually mean and how to use them within a context. So basically, she had 2 aspects she wanted to talk about. One was about social justice, and the other one was about academic justice in relationship to engaged scholarship. So I'm going to throw these out, and then I'm going to open it up for your thoughts and ideas. Her idea about engaged social justice was to have engaged scholarship from within UCT. So she was saying that often when we think about engaged scholarship, we think about the communities that we're working with. We think about the service and the engagement with external to UCT. But she was saying, what would it look like if we had engaged scholarship within UCT and with different stakeholders within the institution. And the example that she gave was actually about mental health, which is interesting. I don't know how many of you are aware that at the moment we have a small crisis within UCT in terms of mental health. The number of staff who are actually going to see psychologists has increased, and there's a lot more counseling being drawn on within UCT. So there seems to be a small mental health issue that's actually becoming a bigger issue. So she was saying, how could you bring engagement home? How could you bring it into the institution? So that was the first point, and I haven't done it quite as thoroughly as she did. But the second point she made was about academic justice. And her point was that why do a lot of committed scholars from UCT, committed academics who have been doing a lot of engaged scholarship, leave UCT? Why do they leave UCT and then go to the NGO sector and become advocates and become very active outside of UCT? And she gave the example of Doctors Without Borders. She asked the question, if we created a different environment internally, would we be able to retain scholars who want to be more, have more advocacy within their teaching and their research portfolios? And what would UCT need to do to nurture that kind of platform so that we could retain scholars who want to be more active? So those were the 2 points that she made. She talked about social justice within and academic justice for the scholars who are outside. So I'm going to open it up now and ask you, first of all, what you think about engaged scholarship when you came here today, or some of you who are going to be presenting, and what do you think of Katie's ideas that she has thrown on the table? So I open it up. Would anyone like to start the discussion?
Okay, Andrea, I will.
Thank you. Please.
Do you want me to introduce myself?
Yes, that would be
So
great.
I'm Lucy Johnson. I'm from the Health Policy and Systems Division. And I suppose those two issues make me think about scholarship as being part of our everyday lives, not something that is invested only in a special research endeavor done on other people, if you like, but how we draw on our scholarship as to inform the functioning of the university and the engagement within the university, so that advocacy is a part of what we do, not something we need the university to do, so that whatever work we do feeds back into the way the university itself is managed and run. So I think that for me is saying, research isn't something out there, it's something in here, and how do we bring that then to our daily function?
Yeah, and that's very true. That's well said. Other thoughts? Comments on that? Yes? If you could just introduce yourself, please.
I'm Stephen Craven from the Department of Primary Medicine. If you want to retain scholars and run a show on the scale of Medicine Sans Frontier, you're going to have to raise the necessary funds. From where?
Okay, good point. Very good point. Other thoughts? Yeah, Landon?
I'm Landon. I work in the Division of Epidemiology. It strikes me that different organizations within a complex society have different niches. And one of our niches should be around, can be around social justice. But the niche that a university occupies that MSF doesn't occupy, the other sector doesn't occupy, research council doesn't occupy, is training. And I wonder if there are ways to link some of Betsy's messages to our training activities and developing researchers and the ethos in which we develop researchers, the kinds of researchers who we bring forward to be the next generation and promulgate some of these ideas. And so I think a do think that one of our unique niches as a university within a society is in training and teaching at all levels. And I think that has to be core to the kind of vision that Hetty and others.
I think that's a very important point, because we're not an NGO, although we do advocacy work. I mean, I think it's an incredibly important point. And sort of linking to the 3 points that have been made already, what for me I think is really important is the way we sort of honor our staff in terms of our ad hoc promotion. And, if we really want to have bringing in the scholarship aspect or the engaged scholarship aspect to our teaching, if we want to have the right funding for it, we also need to look at the way our ad hominem promotion is working, and the way we look at social responsiveness, and the way we reward academics for their engaged scholarship work that they do. And I think in a way it's an evolving concept that the university is still engaging with. So that's why this conversation is really important, is that, how do we actually make sure it's reflected within what we're doing? How would we bring it more into the curriculum? We talk about decolonization of the curriculum. So how do we actually bring in teaching this component of engaged scholarship? Lacey?
I think maybe the DBC's comment is taken from a university perspective, and that's fair enough. But I don't think actually we have a problem producing students and staff who go and see themselves in the civil society sector, because that's a good relationship with training people and skills who work in that area, and we build relationships. Our relationship with MSF with students beneficial to us because of the kind of partnership and the people who do our favorite. But I'm not sure that's the critical problem for us. I think it's the other side. It's actually the people who know that the engagement of the university and the community that is important, totally important, because we get no support. Actually, the system just undermine us. Rather than the CBC does it with us. And I agree, we should be training better in the way that we train us to see a different way of working at the public training. But I'm not so sure we should promote the fact that our parents still find their ways in different places. That's a good thing.
And I think you're right. I mean, that has actually been one of our calling cards in public health.
So just building on Daisy's comments, I was speaking to the director of the Max Planck Institute in Germany, and they have a slightly different problem because they have so many academics working in the institute. But he was basically saying their model is actually that they are training individuals, and lots of them will actually move into leadership. And they see that as something that's actually necessary. That there is this pyramid, and it's saturated, and it's not a failure to move across. And perhaps we have a slightly different scenario because we don't have as many academics involved in our institute, but that movement is also seen as a positive movement to try and train and build up capacity.
Yeah, that's a very good point as well. Yeah, thank you. That's a very good point.
Hello, this is Oliver from the Division of Environmental, and for me, engaged scholarship is trying to bring engaged, using it in our research. And I think it's not only a broader social responsiveness, but more just sort of knowledge generation with partners in the community. So it's about co-creation of knowledge, forming good partnerships, quality engagement with partners to bring about sustainable impact within our research.
Thank you. That's a very good point. Are there other thoughts? Perhaps some issues or concerns that you've had in terms of engaged scholarship? You've been doing your own research. Any other thoughts about that? So, yeah.
On the first point of mental health within the university, maybe we don't also need to see that as necessarily a bad element, that people are actually seeking help. So maybe the problems were there previously, but that individuals weren't
Well, it's an interesting concept that she's brought it into this sort of social justice within the university, because I'm not sure if it's the sort of detail behind it in terms of, is it, that more people are comfortable in actually seeking help, or is it actually because we're taking a strain in terms of austerity measures? And that seems to be what's the indication, that because of the quite a lot of people who've taken the golden handshake, and there are positions now that have been frozen. There are a lot more people who have to take on extra work, and so they're seeing an increase of people who are then seeking, well, absenteeism and seeking help. But it's interesting that she has decided to kind of incorporate that into an engaged scholarship context by calling it social justice within the institution. And I think I'd quite like to hear what other people think about that. I mean, it's a new aspect to me to think of it that way, as having this engaged scholarship concept within the institution and linking it specifically to mental health, and particularly to different role players within the institution. Are there any thoughts on that, Lucy?
So one of the things how we approach the whole question of decolonization and transformation. We multiply our research skills and they're quite closely utilized in PhD sociology. We're studying our faculty, looking at the experience of Black registrars, the work that experience of Black registrars. And sociology supervisor made this joke about, well, he's kind of study the village, the faculty. We don't think of ourselves as being not part of the community, but it should. I think there's a whole area of research besides curriculum, which is centered around transformation. We could be equipped to look at the faculty ourselves.
Yeah, I think you're very right, and this mental health issue is a good point. Yeah.
Okay. Sometimes I think that you might be saying, sort yourselves out first before you try and sort everyone else out. I don't know. But one of the things I do think is this, I think it was Maylene who raised it the other day. Things like breastfeeding mothers in the university. There's no support systems, I think, in place for those kinds of things. That we advocate all those things out there, but that sort of stuff not done at home first. So I sometimes think that's a way of kind of reflecting on what we still need in place. So it's just a thing.
But I think sort of building on Leslie's point and going back to the point that I was making about, a lot of what you do in an academic institution is about collecting the points, collecting, for ad hominem promotion, you've got to make sure you published and done research in your teaching and leadership. And if you can do this sort of focus of at home, what's happening within the institution, but link it to research perhaps, or link it to the teaching discussion as well. I think that is also very important, is to see how we can link it. Or asking the question of, is the sort of ad hominem promotion process correct? And where would you? Other thoughts about engaged scholarship? What about those of you who are from outside of UCT? We've got a few people visiting from outside. So those of you who are doing engaged scholarship work, what are your challenges that you're facing?
That's one other thing I was engaging only on Monday, very vigorously with getting feedback from a group of people that I've worked with for a long time. And they were saying, you come here, what have you got to show? What have you got to show? So in many ways, we take a long time to get things done. And I don't know, but that's my engaged scholarship sometimes. I ask for a lot of help from people out there, and I'm not terribly sure if I give a lot back. And I feel we get research, we get PhDs and masters and students through, but what do we
and I'd like to hear from others what examples you've used in terms of giving back when you've done your research. Are there examples? What kinds of things have you done to give back? Mary?
So my name's Mary. I'm from Seattle, Washington, University of Washington. I'm here in the department for the program for this year. One of the things that I thought was really unique in our agriculture sector, a journalist who works at an agriculture center in the U.S. organizes workshops for journalists to come together with researchers and people who are doing the work, and then he translates it to get it into the community. And so he tries to help teach other journalists how to write the story about the data or the results or the impacts that we found in our various projects. So I've never seen anything like that before, frankly, and I thought that was a really great way to engage. And there are other ways that we work with journalists to try to get the message to the community. Otherwise, I don't know quite the best way to reach the community, to tell them what we found, what the issues are in their communities, whether it's pesticides or worker injuries or whatever might build this occupation.
Yeah, I mean, you're touching on, there's quite a lot of layers in terms of giving back. So the one thing is we talk about research translation. You know, how do we actually take the data that we've found, particularly if it's written in a very scientific manner, and present it back to the population you've been doing the research with? And I think very few people do that. I mean, I have colleagues who were, doing biomonitoring on farm laborers, and then they actually found a mechanism for giving the data back to them in terms of using color-coded graphs and all that. But how many people are actually taking, and we're going to hear a lot of research today, and how many people are actually taking the statistics, the analysis, and the findings and putting it within a palatable language that the research subjects can understand, and then the policymakers as well. Sarah?
Yeah, I don't think there's one right way.
Just introduce yourself, please.
I'm sorry. So it's visual social sciences. I don't think there's one right way. It's kind of the system is different within the project, obviously, because the dynamics are different and the space is different. But I think people sometimes forget that asking people is just one option. Figuring out like a way of communicating back, and asking quite very hard. So kind of thinking about that in the research design, actually having a component about alternative dissemination and just kind of discussing with people. Again, that's not an easy process either, but I think we sometimes sit and scratch our heads about it without just asking like, what might be the best way for you to receive this back.
Which is a good point. And often, there's this funding restriction in terms of you're fulfilling your funding needs, and then people might not always have the time to do this participatory engagement beforehand when you're setting the proposal and the research questions. So that's a very good point. This isn't right, is it? Because if we follow this, we're going to be very late. Okay, so we're ready to wrap up. Just one last comment.
Well, it just made me think for comments and thinking about some of the things that I engaged in, that having it be an integrated part of a research summary or research paper or report where people identify what are some recommendations for engaging with the community based on your results, even if it can't actually happen by them, having a recommendation that others might pick up at some point, that it's integrated into results, that there'd be some kind of engagement component.
So you asked about challenges. So one of the things that I'm thinking is that there are different types of research approaches that can be used, and participatory approaches are not well valued in an institution like this, which is dominated by clinical perspectives. And yet participatory research is entirely legitimate and valid in different epistemological traditions. It's also not always that easy to get funded by strong, normal public health funding. So the way we do research has bearing on forms of social engagement. But to do that sort of
Yeah, I mean, there's a lot of layers to it, you know, in terms of the funding and in terms of why you're doing the research, the requirement, also even the ethics, what ethics demands from you. So it's all these layers. And I'm hoping that this discussion that we've had now, that you'll keep in mind some of these issues as we now go into the presentations and we look at what the staff and the students have been doing in terms of engaged scholarship and the type of research we're doing. And keep bringing up these issues and asking questions and ask some of the questions that you've asked now within the different panels. So we'll go ahead and start with panel 1.
Good morning, everybody. Well done on getting here very early and grabbing a good parking, I assume. My name is Jill Olivier. I'm in the Health Policy and Systems Division. And for the next hour, we're going to be having a slightly varied experience. For the first 20 minutes or so, we're going to have Professor Lucy Gilson from the Health Policy and Systems Division, and she's going to be doing a presentation plus some interaction with some colleagues from the Western Cape Department of Health. And then after that, we have Mbai, Mafunda, and Lucy Kanama, who are in the Health Economics unit, in the Health Economics Division, who will be presenting on some of their work after that. Lucy, are you?
I hope so.
Yeah. You got everything you need? Okay.
I hope so.
All right. Off you go.
So, good morning. I'm from the Health Policy and Systems Division, and I'm going to be talking to you about this project that has the slightly unfortunate name of Whole Syst SA. It's not a clinical project. The SYST stands for system. And this is a project that is a collaborative endeavor between UCT School of Public Health, UWC School of Public Health, and our colleagues in the provincial department. And I'm delighted that some of the team are in the room. Leanne Brady from Health Policy and Systems, David Pina, where are you, sir? He was here, he is here. Tony Hawkridge and Tracy Naledi from the Department of Health. So we're really pleased that our colleagues are with us. So this is a project that has sought to do the following: to look at, track, explain the last 20 plus years of health system development in this province, to better understand what changes have been achieved in the health system in the province, in order ultimately to contribute back in informing and in seeking to support the future monitoring and evaluation strategy with respect to health system development in the province. And the project was rooted in a provincial imperative. This is a picture of the current strategic plan for the province, Healthcare 2030. And that plan identified the need for strengthening the health system monitoring and evaluation that will happen moving forward, for strengthening the evaluation of the implementation of the plan. This is not evaluation of programs, it's evaluation of the system as a whole and how it changes over time. So within this project, we've collected a range of data through a range of methods, all qualitative methods. And that includes, as in the photo here, 2 quite large timeline mapping workshops with colleagues, managers from across the different parts of the health system, one in the urban setting, one in the rural setting, bringing people together to learn from them about their experience of health system change as it has unfolded in the province. So what has happened? And to answer that question, we have to remind ourselves of the situation in 1994 and what the situation of health services in the province was then. And we have to remember the legacy of the past that continues to influence the way things function. That healthcare pre-94 had been an instrument of apartheid policy. And the consequence of that was that there wasn't a health system nationally or in any of the 9 provinces in the way the term is now used, for example, by WHO. The nature of health services was fragmented and divided, managerial authority was fragmented and divided, and hospitals were dominant in the system. In fact, there wasn't really primary care. There were services, but they were often run as hospital outposts. And of course, there was rampant and blatant racism in the way services were provided, in the very operations of services. If you look at that bottom quote, in the way things happened in the services, there was racism. But in 1994, there was a visionary plan for the future. This is a picture of the ANC health plan, the plan for the country as a whole, that provided a roadmap for the development of the health system in the country and within provinces. And this province had particular advantages that were resource advantages in its economic situation, in its health service situation, in terms of the administrative capital that we represent a part of, as well as in administrative capacity. So what's happened? What have been the achievements in terms of the health system over the last 20 plus years? This slide tries to represent the change in the system from a hospital-dominated, fragmented system, or set of services really, to the construction of a multi-tiered, multi-layered system that is where the primary care platform has been strengthened, where the district health system has been established, where there have been efforts to draw out drainage areas so that there can be appropriate referral up the system, and with a strong public sector focus as the public sector serves the needs of the majority of the population. So there's been a move towards a strengthening of the system and the base of the system. And this slide shows the reallocation of resources to the district health system. It represents the percent of total expenditure per budget program. And the district health system has benefited from a reallocation towards that system. This is for the province only. And in this slide, we also have the national perspective and the perspective of the Gauteng province, which is a province that had a similar inheritance of high-level hospitals. So the Western Cape hasn't achieved the levels of the national situation, but it has exceeded the levels that have been achieved in Gauteng in terms of allocation of resources towards the district health system. And on the platform of a stronger base, it has been possible to improve primary healthcare performance. This slide shows antenatal care visits before 20 weeks and the improvement over time in the Western Cape relative to other provinces. Now, of course, there are problems in the way services run, and not everything is perfect. No health system is perfect, in fact. But there have been improvements over time, and it's not only in primary healthcare, it's in aspects of programs, and it's in aspects of hospital performance as well. But our interest is in understanding how that's been possible. What has underlain those improvements? And our work suggests that we can see a threefold change in the system. We can see system-wide changes, system-deep changes, and coordinated changes that have been sustained over time. By system-wide, I'm referring to changes across the various so-called building blocks, as WHO terms it, of the system, that work together to strengthen the district health system platform. And by system-deep, I'm talking about changes not only in, for example, the construction of Khayelitsha and Mitchells Plain District Hospital, but also in the management and planning processes within the system. And very importantly, real efforts to address the organizational culture of the system, to seek to move towards a more patient-centered and person-centered approach to service delivery and approach to management. Now, on this slide, what we've tried to do is represent over time a series of some of the most critical changes in the building blocks. Each color represents a different building block in the system, and you can see there's been constant change over time, and there still is change. It's ongoing. And they are not random changes. They are deliberate efforts to purposefully build a stronger, particularly district health system platform, and to improve quality of care across the platform. But this has been sustained change over time. So what we've seen, as in this definition of whole system change, is a series of processes across the system working with multiple actors to strengthen and develop the system as a whole. But we can't stop there. We have to ask, well, how has that been possible? And here we have identified 4 groups of factors: sound governance and stable leadership, stakeholder management, bureaucratic effectiveness, and evidence-informed decision-making and learning processes, underpinned by context. Remember that resourcing advantage. that I spoke about. And these factors are reflected in international experience of seeking to understand whole system change as well. So just to give you a few illustrations of that, the province has had 3 successive strategic health plans. Each of them has been different. Each of them has built on the previous one. And in fact, they've all built on the ANC health plan. They've all had as a common vision strengthening the district health system and strengthening primary health care. And that common vision has provided a framing device to take people in the system towards that goal. The province has also benefited from strong and stable leadership, and these 2 quotes reflect on that. On the one hand, there has been much less turnover in the heads of departments and the MECs in this province compared to any other province. And secondly, there is a clear sense in the province of an appropriate division between the administrative sphere of governance and the political sphere of governance. And that is not the same in other provinces. There are also immense numbers of characters in this system, people across the system, not just those at the top, but those working throughout the system, who've demonstrated enormous commitment to making changes in the part of the system that they're working in seeking to serve the public in the way that they deliver services, in the way they manage services in their strategic planning for the system. And as a different element, the province has a reputation for robust internal governance systems and strong financial discipline. The slide shows the number of audits by province for the health sector, and this is the audit judgments issued by the Auditor General, and this is the only province that has consistently secured what are called unqualified audits, which is a reflection of strong managerial capacity and processes in the system. And yet, of course, there have been challenges. And those challenges include, in this province, as in other provinces, a continuing quite strong biomedical model of primary health care, and linked to that, relatively weak community engagement in the development of the primary health care system. That strong financial discipline has generated what our interviewees often called a compliance culture, a sense that we have to comply with procedures, and that may limit the risks we're prepared to take, the innovation we're prepared to implement. And some have suggested there's been slow learning from past experience. But perhaps the bigger point that's been raised is, given those starting points, the resourcing advantages I identified, perhaps more could have been achieved than has been achieved. And there certainly are intractable inequalities and deprivation within the province that remain incredibly important needs that the system needs to take greater action to address. Now, remember, I started off by saying the intention of this study was to seek to support the province in relation to monitoring and evaluation activities. And we've just begun to think about that as we draw towards the close of the province. And the question we're asking is, how does this body of work contribute to thinking about the learning that needs to occur within the system to continue and deepen the process of whole system change? So we're not talking about how to strengthen program monitoring. And colleagues like Andrew Bull are working very closely with the provincial department in developing the information platform. What we're trying to think about is how this sort of work can talk back to health system evaluation. Are there data sets that can be combined between human resources, for example, as well as service delivery? Are there new assessment areas that would be worth looking at, such as the notion of public value that the system is ultimately seeking to create? And how can the system go about establishing processes of reflection and learning that enable and support continuing change? Now, is this socially engaged research? I've put up 2 questions here with respect to that. One is to do with that this is part of an engagement and a broader engagement with the provincial department. And really, it's for those colleagues then to ask the question, what are the value and limits of this type of research engagement? But it's also for our students as we seek to feed this work and other work back into our teaching and to learn from that teaching. Unfortunately, our students who are working in this sort of terrain are either radically trying to finish their dissertations as we speak or have already finished. But it's really great that we have our colleagues from the provincial department with us. And I've asked them to consider this question and to provide some reflections from this project with respect to the worth of it in relation to their needs and their activities moving forward. And I think Tony's going to lead the input, but others may join in afterwards. Thank you, Tony.
Good morning, everybody. I'll kick off, and I'm sure David and Tracy might want to say anything as well. So I've just got 2 points on each. So Lucy asked us to think about value and about limits. So the first point on value is, David's made this point before, in the department, when you go to departmental meetings, and the only people present are from the department, it's like sitting in an echo chamber. So we all agree with each other, and you don't hear the opposing views. And so what this project has done for us, and another illustration maybe is those of you over 50, how good are you at taking selfies? I'm really bad at selfies, so I usually have to ask my kids to take it for me. But this has been so we don't. This has been an effort to try and provide us with. It's more like a movie than a snapshot of the department, but the advantages was taken by someone else, not by ourselves. So it's been that sort of experience of getting outside input to inform our decisions and to inform our decision making. The other thing was really about being part of the process. So Helen Schneider made a sort of offhand comment at the recent meeting, I think today, where she said, do you realize that you people are actually our research field? You are our research subject. We're coming to you and to collect data and to synthesize it and to write papers on it. And you could do that. And I'm sure that happens all the time when you publish and we never read the articles. But this way, we've been part of the process right from the start. It actually kept it up there, kept it visible, and forced us to engage with it, because we kind of have to take responsibility for it. And in papers, we'd probably be listed as collaborators or even as co-authors. So we have to agree with what's coming out of it. So that's 2 points on value, and I'm sure the others would like to add maybe. And then just in terms of limits, so it's very valuable information coming out of this, particularly what's worked in the past, what's not worked in the past, what's facilitated changes, what's obstructed changes, and so on. But it's a huge department. It's 33,000 people, and it's kind of like an oil tanker progressing along its way. And to use that information to turn the oil tanker in a different direction is difficult. I mean, I'm sure that applies to all research, but it certainly applies to this as well. And then the other thing is I call it the intangible nature of the subject material. So I come out of a sort of quantitative and biomedical research background, and I've had to come to grips with a whole new vocabulary, which Lucy and colleagues speak. And we're gradually getting there. But communicating that to my colleagues in the department is not easy. So you first got to get to grips with it yourself, and then you've got to kind of make it real for the rest of the people in your units. I think I've probably said enough, but Tracy, David?
Morning, everyone. I'm Tracy. I live in the Department of Health. I just wanted to comment in the area session, you spoke about participatory methods, and just to maybe not necessarily speak about the project, but the CREE project is in that actually it was because of the relationships that we had and working together, and the journal club, the Health Systems Journal Club that we've been coming to now 3 years or longer, I don't know how long it's been, that actually spurred on this work. This work didn't just kind of come, it was through engagement. And actually, when we were doing Healthcare 2030, it was round about the time when the Journal Club was being set up, and a lot of the thinking that we were being introduced to within the Journal Club got infused into our strategy document of 2030. So I definitely feel that the approaches have been very engaging and have been very developmental for us as a department. And what we're excited about is the so what. Often research is done, published, and then it sits in a, whatever. You get your brownie points for publishing or whatever. But the point is, what we're excited about is the next phase, to say, now that we've found out all these things, how does it help us in terms of learning going forward? So the answer from our side is that yes, it seems so.
And David, would you like to add anything? These are all members of the research team, I hasten to add.
So I'm going to be on the so value, I'll speak from a personal perspective. The value for me has been meeting and engaging with researchers, learning about the methods which I enjoy, but also giving me an opportunity to, in a sense, remove myself from the hustle and bustle of what I'm doing, to be able to see our health system in a national context, in a global context, and to understand and to realize, to reaffirm that it's part of a bigger picture, and to actually, in a sense, get quite excited about what I'm doing in where I am, and realize that there's quite a lot of stake, and it's quite, I like that. It's very, very valuable to me, and I look forward to that, to ongoing engagement around that. The limits, Tony kind of said it, the echo chamber thing. So when I think about the department, I kind of think of it as frontline staff and everyone above frontline staff. You know what I mean? And so by frontline staff, I mean the reality of life in a fully resourced health system. And then everyone above that who can get this, we can build these elaborate theories and elaborate edifices of how the system is moving from one direction to another. We can all agree, but we might speak to people on the ground, and they might tell us their reality, which is better than what 20 years ago. Probably will. I mean, some will, some. And that to me is something I've always struggled with. In fact, I'm struggling with it right now. And I are, well, I've certainly been tasked with the job of trying to figure out how to communicate some of this information, what you just very elegantly put to the department as a whole. And it is that we are a little bit stuck on the so what traffic. So it's fine for the people above frontline levels. Very fascinating. But for the people, I'm struggling with the so what for the people at frontline level. That's what I'm.
Great. Good, a good place to end it, I think. Nothing's perfect. Thank you so much to the colleagues, and thanks to everybody.
Thank you. While Humbai is getting her presentation set up, let's just see if there are any questions from the audience to anybody who spoke. Before that, I just wanted to mention, we had the great privilege of having a number of our public health colleagues come to an academic conference last year and present on his work there as well. And I think it was another wonderful experience of crossover between the academic and the practitioner space as well. And just a thought as well, based on the discussion earlier with Andrea, was sometimes is the importance of research partners being engaged in the research question formation, which is something that Tony touched on and Tracy touched on. So I think that might be worth a conversation later. Any questions? We've got a couple of minutes. Yes, sir.
Thank you. We told that you work on changes since the government, specifically to that year's account. But I've been working in both the private sector and the provincial sector for 40 years. And 40 years ago, nobody in the old state province, irrespective of his racial definition, went without disease and injury management because he could not afford it. The private hospitals were inconspicuous. I could count them on the fingers of one hand. If a chap needed it, he got it. And the waiting lists, I can recall a humble African patient with a nasty looking destroyed hip. He had to wait 4 days to get his hip replacement, for which he had to pay the exorbitant fee of 10 rands.
Sorry, we only have a short time. What is the question?
The point he says, we must look back to that system, which, despite the faults of Grand Apartheid, was providing a service to everybody in the through the district surgeons.
Okay. And actually, the district surgeon discussion has come up quite a lot in the conversation. Lucy, do you have a quick response to that? Quite a complex.
A very complex comment. Looking back is always important to understand how things have changed, but looking back must be done with lenses that are not rosy hued. And I think there would be some considerable contestation around the picture of the past health system that you represented. And I do not think that is everybody's experience in the same way that David's reflected that the current picture is not everybody's experience. David has a point. Sure.
Well, just a little because I was actually just watching on YouTube last night the video of Wix. One of the slides that really struck me was he showed the population of Cape Town from 1900 to 2010, and just shows this gradual linear increase, and 1940 becomes exponential, and literally exponential, and has continued to do so, and there hasn't been a commensurate increase in obviously the health time. So that sure in part explains some of this.
We do have a couple of more minutes on this presentation, if you don't mind just hanging. Any other comments or questions that we might not be able to field them all, but if we can at least gather some more. Any other thoughts? No? Oh, sorry.
No, thanks very much. In the Department of Health, since 1994, there's been a number of restructuring processes that have been very energy intensive and so on, and we're busy with another one at the moment. I'd like to know from your research what reflections there have been about the value of those, and how they've panned out, and the rationale that you see for the various restructuring processes that have taken place.
Thanks, Martina. I don't see other hands.
Okay, so there is a process that's going on right now, but our work has only begun to gather insights on that. I think I can currently comment on that one. Previous processes, as David said, people have different experiences. So, one presents a synthesized version, as I've just done, but within the system, people have different experiences, some positive, some less positive. Organizational change is always challenging. But I think across the board, the sense that the provincial department has sought to move towards a more coherent system founded in a strong primary healthcare base is something that most people in the department do accept and buy into, notwithstanding the fact that they don't necessarily like all the bits and pieces of the digital process.
Tony or Tracy, did you want to? Sorry, I can't see you from here. No? Okay, you good. Okay, Ellie.
I'm just listening to talking about the district health, the district surgery system. I think in the school it might be useful to have a little hub where we deposit some sentinel work that's been done by the school, very engaged fellowship kind of work. In terms of ophthalmics unit, Diane McIntyre's done an incredible review of that district surgeon system, and in fact it had significant, I think, impact on that particular system and what happened after it. So I'm just thinking as we're going along, it would be nice to have a repository for the school to one could access some of these absolutely sentinel papers that came out of the school that had significantly influenced the health system, not just in the Western Cape, but also nationally, and informed it in a variety of ways.
Oh, thanks, Mary. It reminds me how the HOLSIS project emerged out of connections between a number of different research projects, and it's a reminder of the importance of maybe creating stronger connections between a number of different divisions and research projects and units, and how much value that can be. Andrew, did you have a question? I saw a hand this way.
Just sort of a quick reflection is, I was wondering how is this information and research being infiltrated or sort of moving into the undergraduate curriculum? So the next layer of people who are moving into the health system. So I know it's sort of getting into the postgraduates and there's discussions, but it seems to me it's really important that the findings of this research also filter into the undergraduate education, because they're the next health system layer.
Okay. I'm going to take that as a comment rather than a question, suggestion. I don't think there's any direct engagement with undergraduate teaching other than the infusion of ideas. Did you have a hand? I wasn't sure. I can't see you behind.
It's actually a good idea. We can reflect on it in the debate.
Great. All right, I think we need to move on. Thank you, everybody. Thank you to the whole team. I'll let you introduce your own topic.
Good morning, everyone. My name is Vimbai, and this work on the socioeconomic variations in patient outcomes associated with the psychosocial intervention for patients with diabetes and HIV in South Africa is a collaboration between UCT, the MRC, and the Western Cape Department of Health. As you all know, South Africa has a quadruple burden of disease, which includes chronic communicable, non-communicable disorders, injuries, and mental health disorders. Our country has the largest ART program in the world and a significant diabetes prevalence. There's also a large burden of mental illness, such as depression, and estimates are that 1 in 10 people will suffer from depression in their lifetime. However, despite this burden, the treatment gap for common mental disorders is large, with limited, if any, treatment available in the primary healthcare service. So we have a problem of chronicity in physical disease, coupled with mental illness comorbidity. The negative implications of this combination are well documented. For example, diabetics with depression are known to have poorer adherence to their treatment protocols, resulting in more complications, hospitalizations, increased healthcare expenditures, and poorer productivity compared to diabetics without depression. And in a context where up to 45% of diabetics will experience depression, this is a major public health problem. And a similar picture can be painted for HIV. Inequities in health outcomes and economic burden evident for HIV and other conditions in our high burden underserved settings are expected to increase with mental illness comorbidity. There are many complex interactions between mental illness and poverty. Poverty is a risk factor for mental illness, and mental health problems can increase the risk of drifting into poverty. This is known as the social drift hypothesis. Mental health interventions can help limit the potential of social drift. Systematic reviews have highlighted that there's limited evidence on the economic consequences of chronic disease and comorbidity with mental illness. This current analysis is part of a wider economic evaluation of Project Mind and includes a patient's socioeconomic impact evaluation, which provides a broad context for today's analysis, which is really an exploratory analysis aiming to examine the impact of the mental health intervention on health-related quality of life, depression outcomes for people with diabetes and HIV across a range of socioeconomic indicators. Hopefully, this will give us an insight as to whether the poorer people in our sample can benefit from the intervention in a comparable way to those who are richer. So what is the Mind intervention? It's a psychosocial counseling intervention aimed at diabetics and people living with HIV who also have depression and alcohol misuse problems. It uses problem-solving therapy and motivational interviewing. Problem-solving therapy is a solution-oriented approach to managing life's problems, whereas motivational interviewing is a guiding style to client-centered counseling. Both these therapies are widely used in mental and behavioral health care interventions and are uniquely combined here in Project Mind. The overall project aims to test the cost effectiveness of 2 task shifting models for integrating the intervention into the primary healthcare service for diabetes and HIV. Data used in the analysis was collected during the pilot study of the project conducted in 2016. In the pilot, we tested the 2 models at 4 primary healthcare facilities. The facilities were located in metro and non-metro sites, which had a high burden of disease, high unemployment, and crime. In the pilot, we enrolled 40 patients, and the intervention consisted of 3 counseling sessions based on motivational interviewing and problem-solving therapy. Patient data collected included demographic data, socioeconomic status data, health outcomes, and patient costs. We used a pre-post methodology looking at outcomes for depression, functional status, and general well-being using the CESD and the EQ5D tools respectively. An improvement in quality of life is reflected by an increase in the index value, and an improvement in depression is reflected by a decrease in the CESD score. We measured socioeconomic status using assets, employment, and education. We then created an asset index using the multiple correspondence analysis approach, which included indicators on housing structure, access to services, and ownership of household assets. Patients were then categorized into broad, lower, or higher socioeconomic status groups. For example, on the employment indicator, patients were categorized as either employed or unemployed. So the results show a sample that consisted mainly of middle-aged women who have some high school education. At baseline, most of the sample was unemployed and also at follow-up. And the sample was split evenly between chronic disease patients, between HIV and diabetes patients. Looking at our health-related quality of life, we can see a general improvement in health-related quality of life. And the diabetes population appears to be slightly more responsive to the intervention than the HIV population, suggesting something about the effectiveness of the existing adherence counseling targeted at HIV patients. When we look at quality of life by socioeconomic status, the change in the quality of life estimate is larger and significant when using the asset index as a measure of socioeconomic status. But looking at health-related quality of life for HIV by socioeconomic status, we see that the lower socioeconomic status group generally has larger changes in quality of life than the richer group. Looking at our depression outcomes, we again see a general improvement in depressive symptoms across all groups. The depression score by socioeconomic status shows us that for the lower socioeconomic group, the change in the CESD is larger when we're using employment as a measure of socioeconomic status, and this could be attributed to 2 of the patients finding employment within the follow-up period. Our outcomes for depression and diabetes by socioeconomic status show that changes in employment again may explain the significantly larger results in the employment indicator for the lower group. So what can we conclude from these results? Our main conclusion is that the intervention has a promising impact on patients' health-related quality of life and depression outcomes, and may be appropriate for patients with common mental disorders and physical disease comorbidity. These promising health outcomes for the poor suggest that mental health interventions may also contribute to reducing inequities in outcomes for chronic disease. And as a take-home, the results suggest that the poorer are able to benefit from the intervention in a similar way to the richer. This is a promising intervention outcome in a highly inequitable and resource-constrained health system. The results were limited by the small sample size and the short follow-up period. On engaged scholarship, the Western Cape Department of Health are collaborators in this project. A collaborative approach to introducing the mental health services is necessary in a context where the need for treatment is limited by systemic resource constraints. A stakeholder advisory group was developed, which is a forum where all aspects of the intervention are discussed, and the Department of Health representatives are active members in this forum, as are the patient representative groups such as Diabetes SA. On the ground, the time and motion tool developed for costing the intervention is now being considered as part of the NGO reporting framework to the Department of Health. Implementation workshops are also being conducted at all facilities with the aim of collaboratively negotiating facility capacity for intervention delivery and highlighting barriers to implementation. I'd like to thank our collaborative team and our funders and the Project Mind group. Thank you.
Thank you, Mumbai. I should have mentioned earlier, this is your PhD work, right? Now is a PhD student in the Health Economics Division. Lucy, while you come up with your presentation, let's see if there are any questions. And I see there's a number of people in your collaborative team here in the audience, so maybe they would want to give a question or a comment as well. Any?
Yeah, thanks.
models that you were testing to see which worked better, can you perhaps explain what those models really were and if there were any differences between models, what we were to better than others?
We didn't test them in, so the pilot tested them, but we didn't get, okay, let me just explain the models. So the first one is the dedicated approach, in which a counsellor is dedicated just to delivering the intervention. So they would introduce a counsellor, and then in the designated approach, they would take an adherence counsellor who's already existing in the HIV team and use them to deliver the intervention on top of their other responsibilities. And we had 4 facilities, so we weren't able to see which model works best. We just used the dedicated, which is the project team counselor.
Okay. Dan and then Leslie.
Thank you very much. I can understand the reasons for that and the difficult distinction between poorer and richer households. But I was wondering if there is something in the real life experience of what I mean by that is like you can have someone who's employed and someone who's unemployed. But the unemployed could be living in a house that actually has a greater per capita income than other people around them. So I'm just wondering whether it says if you have a 2% of whether there's a real difference in the living conditions of the worker.
Let's take a few more questions, then you can answer them together. Leslie?
Thanks very much. I understand it's a pilot, but I'm just wondering what's coming afterwards. And for instance, the idea that a police post shows changes in other contexts, one would be worried about how sustainable it is for the movement practice. And if it's in health economics, are you going to be doing a costing of this intervention to see whether it works?
Okay. All right, just take one more and then you can.
You mentioned it as a Mastercard, but I'm keen to know how many of your pilot attended all 3 sessions. What the biggest part of the project is, let out. So, for your main 1200, I'd like to know how many people actually attended all 3.
Okay, I think that's enough.
On the distinction, because we weren't sure if we could distinguish just by using assets, so that's why we used the assets and the education to try and distinguish the population. And we thought we might not be able to distinguish people whether they're rich or poor, but we were able to see some sort of distinction within that small sample. That especially using the asset index, that we actually could see some variation in people's socioeconomic status using assets. Does that answer your question?
Formal discussion over tea. All right. And the Leslie's question about. Oh, sorry. Okay. So there is income data, but you haven't analyzed. Right. And Leslie's question about what happens afterwards.
Actually, the costing is the main thing, but we obviously couldn't do that on the pilot, so that's to come, and we're collecting the data on that now.
Okay, and then finally the dropouts, do they all attend the 3 sessions?
We enrolled 40 and then 2 dropped out, so we lost 2 to follow up. So we ended up having 38. Yes, yeah. Yes, in the main study, which is ongoing. So we are aiming to have 1,200. I think the sample is 1,260. So we're aiming to have 1,200.
Okay, and that's all we have time for. Thank you very much, Mbali. And another Lucy who's in health sciences.
So my name is Lucy Kanema and I work in the Health Economics Unit. And today I'll be discussing a review of the quality of tuberculosis costing studies to date. So the background to this is a group called the Global Health Cost Consortium, which is a Bill and Melinda Gates funded project, which works together with University of Washington, Avenir Health, University of San Francisco, London School, INSP in Mexico, and the University of Cape Town. We're a large group that have previous experience in costing, both of TB and HIV projects. And the primary outcome of this project will be to produce an updated, easy-to-use unit cost database for both HIV and TB. And this should be tailored to a variety of use cases and well integrated with existing costs in order to help decision making. So currently we're performing a systematic review of TB costing studies. And this is to inform literature gaps and understand areas of TB costing, to assess the need for a reference case for global health costing, and to assess the quality of previous costing to date. And ultimately, we hope to have a publicly available database of these costs. And the idea is to then have tools that one could go in and manipulate these costs to try and extrapolate across different settings for countries that don't have good data for HIV and TB costs. So an initial piece of work was to run a survey where we asked for those using cost data produced by others, have they recently used cost data that they did not produce themselves? And the answer was a resounding yes. How difficult was this data to find? And the majority, well, half of the group, which was around 270 individuals, found that data was quite difficult to find. And then how difficult or easy was this to apply for your own purposes? Again, around half the group found it relatively difficult to apply this data for their own purposes. And there were issues with the data that would limit the efforts to try and extrapolate or adjust the cost data. Part of this was to do with the cost ingredients which were used, so not being transparent about which elements were included in the costs, and how overhead costs were calculated and so on. Then in order to do the systematic literature review, we searched on the following electronic databases and then included grey literature as well. Our search strategy was to incorporate these three elements, so words related to cost, words related to tuberculosis, and then words related to treatment. And just to emphasize that our group is responsible for the TB costing studies, and there's another group that is responsible for the HIV costing studies. We didn't have a strict limit on the dates, so we ran the review from 1990 to 2016, and we didn't restrict by country or language. We then had an exclusion process where if the costs were actually modeled or secondary, we did not include these studies. So we're interested here in empirical work to do with either prices or quantities. So one would need to go into a facility and actually look at the prices and quantities there. And as an exclusion criteria, we also excluded high-income countries. Then as we went through, we have an inference process where if we're able to infer, we do. But if there's not enough information to infer, we have a process where we have a team go through and see if we agree. So just to say that initially we found 16,000 records and then 5,000 additional records. Going through this process of screening, we then found that we have 207 studies for inclusion, and to date we've extracted 75. These 75 TB provider cost studies, and we will be extracting on patient cost studies as well, are extracted into a multi-field data extraction tool, which has an aspect that looks at methodology and then also the costs of studies. It's a large spreadsheet, and each study takes between 5 and sometimes 8 hours to extract, depending on how many costs are included. So for instance, we might find that there are 150 costs in a paper. it's a work in progress, and there's a team working on this. We're looking at published studies, any provider cost for any TB intervention, and we're looking to see if things are explicitly included and mentioned, or if we are able to infer if something is included. So of the 75 studies, we see a range of dates, but there's quite a lot of recent work being done from 2009 onwards, and we see 14 in 2005. So what we've done is we've looked at various elements. So we've looked at scope, and here we see that there's varied reporting on elements of scope, varied reporting on sampling, where, for instance, we can see that there's some sampling done at the site level, but not a lot done at other levels. The methods used are also varied. We do see that the majority of studies don't actually report on how they allocate their costs. When we look at inclusion of costs, we see that there are a lot of papers that don't actually have overheads included, or they're not reporting on overheads. And when we get to things like discount rates, there are some studies that are reporting on discount rate. The majority of studies do report on currency year, and some report on conversion method. So I'll just skip through this, but basically to emphasize that we are looking at each of these different elements for all of the studies. And we find that there is cost data for TB from providers' perspective available. However, it's not all recent, and reporting varies greatly. We are interested in looking at various different interventions, and we're finding that there are gaps in the literature. For instance, childhood TB is one of the neglected areas. There is a variation in the methods used, such as discount rate and sensitivity analysis. And what we're encouraging is that researchers be explicit and transparent about how they cost interventions. And we feel that a reference case will help with this. And the final larger data set will also help us assess the quality and be available for others. So then just to look at how we've engaged with scholarship, well, through engaged scholarship. So the process has been that in the beginning, there was a lot of engagement with UNAIDS, PEPFAR, WHO TB, in order to try and inform how we went about this process and for what purpose this work will be used. And then the products, such as the reference case for estimating global health services, will help both the users and producers of costs. And the guidelines on tuberculosis, so will help to inform how we actually do this costing. And then we have a technical advisory group of 25 members and a stakeholder group of also 25 members, and annual separate meetings with those. So these are the organizations that the advisors and technical and stakeholders are from.
Thanks, Lucy. I think it's a good reminder of engaged scholarship also is responding to broad stakeholder questions. I know there's a number of different systematic review projects going on in the school. Some more kind of quantitative based, some integrating qualitative across all the different divisions. That might be a conversation for later. And I think there's also that Global Evidence Summit happening in a couple of weeks' time where there's a strong focus on utilizing systematic review to answer society's questions in health. So that might be something worth a conversation later. A couple of minutes for questions.